Okay.
Hey, Vaughn.
Hi, Chris.
Hey, Professor.
Hi, Marlon. Hi, Mary. All right, so I'm recording to the cloud, so a lot of people are missing, so it'll be recorded.
Okay.
So classes are canceled for tomorrow. Did Kim say you still have to go to the hospital? No? Okay.
Negative. Gretchen had her warehouse where she keeps her stuff flooded, so she had to move stuff around. She
How
said
come I
she's gonna,
can't hear you?
oh, you can't hear me?
Barely.
Oh,
I can hear Chris.
You can hear him well?
Yeah.
All right, so maybe I have to turn
Gretchen's
up
gonna
my
be about
volume.
10 minutes.
He said Gretchen's going to take around like 10 minutes.
All right, so it must be me, Marlon, because you're very distant also. Hold on one second.
Oh, okay. Okay.
Okay. No, it shows my volume is up. Okay. So repeat what you said.
Chris.
Oh, Gretchen said that she's gonna be 10 minutes.
Oh, okay. All right, so I'll go ahead and get started. It's not a long lecture. There's three things that we need to speak about. The 6-minute walk test, a pulmonary stress test, got some funky numbers associated with it, and then what metabolic cart testing is for. So those three things, it shouldn't take us long. To start off, the 6-minute walk test is you're walking a patient as far as possible in 6 minutes. You measure the distance that they walk in the 6 minutes, and that becomes something that you enter on the report. So I don't know if you guys have had to walk any patients and do a 6-minute test. You have? Did you measure how far they were walking, or it was just come with me for 6 minutes? Oh, she did. Oh, okay, very good. I know I was with some students at Memorial last year, and there was no measuring. It was walk around the nurse's station, 6 minutes are up, look at the O2 sat, heart rate, and that's what got reported, and work of breathing. But the official 6-minute walk test, you're supposed to report the distance. So the test helps with evaluating a patient for surgery. If their lungs are good enough to walk for 6 minutes without desaturation, it tells the surgeon that they're a good candidate for surgery. Because remember, the lungs tend to have smaller lung volumes, retain secretions after surgery. Patients are higher risk for pneumonia after surgery. So surgeons don't want to operate on somebody that has really bad lung function. So they want to evaluate that. Before starting a pulmonary rehab program, how do you evaluate if the patient is improving? And the answer is 6-minute walk test. So you see how far they can walk before they go through rehab, and then how far they can walk after rehab has been completed. Typically, I think it's a 3-month program for pulmonary rehab. 6-minute walk test is used to measure the response to a medical intervention. So it could be a lobectomy, it could be lung transplant, it could be, that's all my imagination can think of. Another reason for doing a 6-minute walk test is evaluating pulmonary hypertension. So when pulmonary hypertension is brought under control, patients are less dyspneic or less short of breath. So that's why they use the 6-minute walk test to see if the pulmonary vasodilators are making a difference in how far they can walk.
Hey, Professor, sorry to interrupt. Tiffany said she's having issues signing in to Zoom, but she's going to get on as soon as she can.
Issues logging into Zoom?
Yeah, she's trying, I think, from her phone. but it's not letting her, but she's going to join as fast as she can.
Oh, okay. Yeah, let her know it's okay. It's being recorded.
Okay, we'll do.
So the objective is for the patient to walk as far as possible in 6 minutes and not to leisurely stroll for 6 minutes, but to also walk as fast as possible for 6 minutes. So that means like your heels have to hit the ground. When you're walking really fast, what's the difference between a walk and a run? The back of your heel touches the ground and that's considered a walk. If the back of your heel doesn't touch the ground, that's considered running. So when you're walking really, really fast, just make sure your heels hit the floor and that's considered a fast walk. Have you guys done this yet in the lab portion? No? Oh, okay. Yeah, I want to know how many laps you guys do. So normal, like if you mark off, you put the cones 50 feet apart when you're doing it. To go down to the cone, come back around and come back to the first cone, that's 100 feet. And you should be able to do 12 laps, walking as far as possible, fast as possible in 6 minutes. You should get through 12 laps. So I want to know how well you guys do. The American Thoracic Society sets the performance standards for this testing. They also set the standards for pulmonary function, predicted values, things like that. So they say that the patient has to walk alone because they find that if you walk next to the patient, you are the one actually setting the pace and they just tend to follow what you're doing. So the patient has to walk alone. It's okay if they stop. They're so short of breath, they can't keep going. It's okay. The clock keeps ticking. Whether they slow down, whether they rest against the wall, it doesn't matter. The clock keeps ticking for 6 minutes. And then if they use oxygen, they can wear their oxygen, usually it's a cannula, during the testing, but they have to carry the oxygen tank. So usually the physical therapy departments have those small canisters of oxygen, like the liquid oxygen, where you just put it on their shoulder. So it's not like they're walking around with an e-cylinder for 6 minutes. It's a little portable O2 device. And if it's not in the respiratory department, then they have it in the physical therapy department. It says, do not encourage them, but only inform them of the elapsed time. Because encouraging changes how they do. You know, if you're rooting for them, come on, I know you can do this, push, you can do this, you can do this. You're changing how their 6-minute walk test results are. So all you can say is this many minutes have elapsed. Prior to and after the test, make sure you monitor their blood pressure, heart rate, respiratory rate, and oxygen saturation. So the distance walked, it says to set up 100 feet. And again, that's like 50, putting the cones 50 feet apart and having walking laps. It can't be 10 feet apart and having them walk, you know, 120 laps or something. So it's supposed to be a certain distance going straight. Turnaround points are marked with a cone. Keep track of the number of laps. On healthy subjects, you should be able to walk 400 to 700 meters. So converting meters to feet, what did I write down? 400 meters is 1,200 feet. So I wrote walking 400 meters is equivalent to walking 1,200 feet. This is considered normal distance for people with normal lungs. And that comes out to 6.6 laps. Just to give you an idea, when you perform it in the lab, I think Kim has you performing it one of these weeks. I'm not sure when. So you should be able to get 6 laps done in 6 minutes. So you keep track of the laps. Oh, it says that already. And then rate their degree of dyspnea. So you have to say on a scale of 0 to 10, how short of breath do you feel? And 10 is the worst, like there's very, very short of breath at number 10. And that's it. That's all I have for 6-minute walk test. Any questions on that? So you have to strap them with an oxygen cylinder. You have to strap them with a pulse ox. So hopefully it's the small little finger one, so it's not really heavy. And you have to time them and keep track of their distance. Yay, you made it. Oh, no kidding. Wow. They shut down the turnpike?
Yeah, real quick, like right when you get, I guess right above commercial, because I had to get off on commercial. And when I got up on commercial, I couldn't go east on commercial. So I had to come back around, try to go up Rock Island. So I just got here.
Wow. How long did that take you?
19 minutes more. I
Wow.
was like one exit away.
Oh my gosh. You are a dedicated student, Brent. Thanks for being here. So all you missed was the 6-minute walk test, but I'm recording it, so you'll be able to listen to it.
Okay, and you're sharing those things with the experience. Thank you for explaining. I really understand.
It's not your fault. I'm just appreciative that you're here. Okay, so we'll go through exercise testing. It's called a cardiopulmonary stress test. And you can see the person performing it. They've got a mouthpiece in their mouth. As they're breathing, their air is being monitored. So the amount of carbon dioxide being produced is being monitored. The amount of oxygen they take in is being monitored. They have a 12 lead EKG. It's obvious on the lady that she's got the 10 leads on for monitoring a 12 lead EKG during the testing. And we're looking to see as they exercise and they become, what is the word that I want to use? Anaerobic, they go into anaerobic metabolism, that's kept track of. And I think that's all I want to tell you until we get to the slides. So to do a cardiopulmonary stress test, you need an ergometer, and that's just a fancy word, meaning a device to measure or impose work. It can be measured in watts or joules per second. Most common is a bicycle, and bicycle is probably the better choice. A treadmill can also be used, but with a bicycle, it's not depending on the patient's weight. So it's just, they get to sit down as they're exercising. So it's more reliable from one person to the next. It says the mouthpiece is connected to a metabolic cart and measures oxygen consumed and carbon dioxide produced. So the mouthpiece is measuring oxygen being consumed and carbon dioxide being produced. And we have a 12 lead on the patient. So if while exercising, there are some ischemic changes noted in the heart, it'll be reflected on the ST segment. So we're looking for changes in the ST segment to indicate cardiac ischemia while exercising. I'll put that in the chat. So the 12 lead EKG is looking for cardiac ischemia. And remember, ischemia means lack of oxygen. Ischemic changes will be noted on the ST segment during exercise if the heart is not getting enough oxygen. And then, of course, we monitor pulse oximetry to see if the patient is desaturating or not. And we monitor their blood pressure. We also monitor the respiratory rate, and that's not listed here. So add respiratory rate to the list. So how the test is conducted is the patient exercises for 8 up to 12 minutes. The workload increases throughout. So if they're on a bicycle, it's really easy to pedal in the beginning, and then they increase the resistance, and then it gets harder and harder to pedal as they're exercising. The test will be stopped if blood pressure is too high, because we don't want to kill the patient. We just want to see how they're doing during the testing. If we see EKG changes or chest pain, we would want to stop the test. If the patient is too short of breath to continue, we stop the test. If they're too fatigued to continue, we stop the test. There's always a physician present during the testing. So typically, the respiratory therapist sets everything up. You call the physician, and then you start the testing once the physician is there. Prepare the patient by obtaining a history and physical exam. Get a resting 12 lead EKG. Calculate the patient's maximum heart rate. Here it shows you take 220 and subtract their age in years to get their maximum heart rate. Then the patient is stressed by riding the cycle ergometer, or if they're on the treadmill, they're walking on the treadmill. We're monitoring EKG, O2 stats. We already talked about that. The patient continues until 80% of maximum heart rate is achieved, or they develop symptoms that indicate the test should be terminated. Does that look like a test question? When should you terminate the test? The heart rate gets up to 80% of their maximum, or those other symptoms that we listed on the previous slide. So let's just go through this. 80% of maximum heart rate. How do we figure out maximum heart rate?
Would it be, I guess, the highest your heart rate can go during the exercise? Okay.
It's 220 and you subtract the age.
Wow.
So if somebody is 40 years old, so 220 minus 40. So a heart rate of 180 would be maximum heart rate. We stop the test when we get to 80% of that number. So 0.8 instead of 80 times 180. Where's my calculator? What is it? 144. Oh, okay, thank you. For example, if the patient is 40 years old, we take 220 and subtract the age. So 220 minus 40 gives us 180. And then we would stop the test when they hit 80% of their maximum. 80% of their maximum would be a heart rate of 144 per minute. So once they hit their maximum heart rate, we stop the test, or if they're too short of breath, we stop the test. And then we gradually reduce the workload and let the patient's vital signs come back to pre-exercise levels. So gradually reducing the workload, just make it easier and easier, but you don't completely stop their movement. It's kind of like a cool down after a workout. So you cool them down by having them gradually slow down, and then you stop the test. So when would you recommend that a patient have a cardiopulmonary stress test? And then just to point out that a cardiopulmonary stress test is different than a cardiac stress test. So cardiac stress test is just looking at the heart. They put in a dye during exercise to see if you've had this done. Ah, okay. You had a cardiac stress test. Did you have to exercise during the testing to see if there's any change? You were on a treadmill? Okay. So that's just looking at the heart. So that's different. That's a cardiac stress test. This is looking at reasons for the person to feel short of breath when exercising. Or if somebody is, no, I want to stop there. So somebody's experiencing shortness of breath on exertion. It's also indicated for athletes training to achieve greater potential. So one of the values that you get from looking at the amount of oxygen being consumed and the amount of carbon dioxide being produced, you see the point where the cells start going into anaerobic metabolism. And I have a slide on that, and it's called their anaerobic threshold. So how long can they exercise and how strenuous can the exercise be before they reach that anaerobic threshold where their cells aren't getting enough oxygen and now they're producing lactic acid. So the more trained they are, the more fit they are, the longer they can exercise before they hit that anaerobic threshold. And then measuring or using a scale to look at shortness of breath. It has a name. I guess Borg must have been the person that decided to call it his or hers. The Borg scale for dyspnea. So it's typically out of scale of 10 with, here it's called perceived exertion or shortness of breath. would be 10 would be a very, very strong perception of overexerting yourself. I found this on the internet and I just found it kind of funny. So level 1, it says, I'm watching TV and eating bonbons. You guys even know what bonbons are? No. It's a confection made out of coconut. It's got like a sugar, confection or sugar coating over it. It's like the stigma of what people do when they don't have to work. You know, the rich and famous sit around and they eat bonbons. Anyway, that's not part of the story. Level 2, I'm comfortable. I could maintain this pace all day long. Level 3, I'm comfortable. I'm breathing a little bit harder. Level 4, I'm sweating a little, but feel good and can carry on a conversation effortlessly. Level 5, I'm just above comfortable. I'm sweating more. I can still talk easily. Level 6, I can still talk, but I'm slightly breathless. Level 7, I can still talk, but I don't really want to. I'm sweating like a pig. I don't think pigs sweat though, do they? Level 8, I can grunt in response to your questions and can only keep this pace for a short time period. Level 9, I am probably going to die. Level 10, I'm dead. So somebody out there has a sense of humor. All we have to remember is the name of the dyspnea scale, the Borg scale. And number 10 is the worst, or severe exertion, severe shortness of breath. Values that get measured during the cardiopulmonary stress test are, the first two I've mentioned, the oxygen consumption, the CO2 production. When the two are compared, it's called the respiratory exchange ratio. So typically at rest, we produce about 200 mLs of carbon dioxide every minute, and we consume about 250 mLs of oxygen every minute. And 200 to 250 gives us that 0.8 ratio. Do you remember doing the alveolar air equation and figuring out the amount of gas in the alveoli? And we had to know the respiratory exchange ratio. So that's where it comes from. So looking for VO2 max, or maximum oxygen consumption, it says while exercising, the amount of oxygen being consumed by the body should continue to increase. So the more we work, the more our cells need oxygen. We should see the oxygen continuing to be consumed at a greater rate. If there is a point where the lungs cannot deliver enough oxygen to the body, it's called VO2 max. At this point, anaerobic metabolism will occur. So if somebody can't get to 80% of the predicted value for their VO2 max, it could indicate that they have cardiac limitation, something going on with their lungs, so respiratory limitation. So somebody with bad COPD, pulmonary fibrosis. It could just be deconditioning. Somebody who doesn't get any exercise and you put them on a treadmill, their muscles are not conditioned and they're going to have an early VO2 max just because they're weak. They can have a normal heart, normal lungs, but because they're out of shape, they're going to hit the VO2 max a lot sooner. And then, of course, poor effort. So that anaerobic threshold, which is the big deal for this testing, it's when energy demands exceed oxygen delivery. And we know that's happening because carbon dioxide will continue to be produced at greater amounts, but there won't be any oxygen making it into the cells. It says at this point, the respiratory exchange ratio will be greater than 1.0. And then looking at the testing results, we know when this happens, it's the beginning of lactic acid production. Lactic acid will cause increased elimination of carbon dioxide. The increased CO2 elimination will be the marker for anaerobic metabolism. So if you were to summarize everything I just talked about, it would be that very bullet. We're looking for CO2 to increase, but not oxygen. I think this arrow moved away from where it's supposed to be. This just was a little bit bigger. So this is somebody who's working. They're monitoring their oxygen, their carbon dioxide. At this point, they're increasing the resistance, or it says work ramp, so it's probably somebody on a treadmill, and they're increasing the angle of the treadmill to make them work harder. So they're monitoring oxygen consumption, which I think at the bottom, it's these little red boxes. The CO2 production is blue. And all we see is kind of like a blue line and maybe some circles, kind of hard to tell because it's small. So the person's exercising. What else are they looking at? Heart rate. So you see the heart rate going up as they're exercising. Minute volume is in green. So this is them breathing. Now they're breathing lots. And then keeping track of oxygen in red and carbon dioxide in blue. Do you see how the two lines separate right here? So we're having more carbon dioxide being produced than oxygen taken up or consumed, as we say. That's the point of the anaerobic threshold. So we say that's the point where the patient has reached their anaerobic threshold. All right, any questions on that? It all boils down to that. When the graph separates, we know that they've got anaerobic metabolism going on because they didn't get enough oxygen delivered to their cells. So that's the big deal with cardiopulmonary stress testing. See if I have any other notes on it. Yeah, I think that was pretty much it. We would expect the cardiac output to keep increasing as the workload increases. So the stroke volume will increase, it'll stabilize. The heart rate increases steadily throughout the test. So that's what you would expect to see. Systolic blood pressure goes up, but you should see a stable diastolic blood pressure. You should see a decreased systemic vascular resistance. Any idea why that would go down? Okay, I like that. Anybody else? Why would the systemic vascular resistance go down? So actually the blood vessels going to the muscles dilate, so you get more blood flowing into the muscles. I'm glad you at least guessed. So as the little arteries dilate, arterioles is it? They dilate to get more blood flowing to the muscles, and that lessens the resistance. So systemic vascular resistance goes down. So what sort of change in the ST segment tells us that this is not good? Hey, wait a minute, the heart muscle is not getting enough oxygen. And it's when you see ST segment depression of 1 millimeter or more. It says it's a significant abnormality noted. It's suggestive of myocardial ischemia. So there's not enough oxygen getting to the heart muscle. That would be an indication for terminating the test. And then the shift to the right and up, it says it's normal. Shift to the right and up. I don't know. I don't even know how to draw that for you. So I just kind of remember what's bad. I remember that ST segment depression is what we're looking for, and it indicates myocardial ischemia. And that was it for cardiopulmonary stress testing. So you have to know when you would recommend it. You would have to know how to set up the testing, what's being measured during the testing, especially the anaerobic threshold, and when to stop the test. All right, so now we've got indirect calorimetry, and somehow or other it's adapted the term metabolic cart, and the physician's order, metabolic cart. So I'll go through it. I feel like I'm not giving you guys your money's worth because we're on the last part of the PowerPoint and it's only been like 35 minutes. We can talk about something else, the weather maybe. All right, so the metabolic cart is a computer cart. It's got some things on it that can measure how much oxygen the patient is taking in, how much CO2 they're producing. And from that, it can figure out how many calories they're burning. Somehow or other, this got put under the umbrella of respiratory therapy. So typically it's part of like the pulmonary function lab will have a metabolic cart, and when the physician orders it, they'll go and measure the oxygen, the CO2, and figure out their calories. So indirect calorimetry, we're looking at the number of calories being used up by the patient. Indirect calorimetry is a technique that measures inspired and expired gas flows, volumes, and concentrations of oxygen and carbon dioxide. Isn't that amazing that from that you can figure out how many calories you're burning? So at the bottom it says, the word indirectly is used because the test indirectly measures the amount of heat produced or calories burned by determining the amount of oxygen consumed and the amount of carbon dioxide eliminated. So it's not directly measuring the calories burned, it's indirectly measuring the calories burned. The equipment used is also known as a metabolic cart. It can be attached to mechanically ventilated patients or somebody who's just breathing room air. If there's any leaks in the circuit, and then on the right it shows if somebody is just breathing room air, they put this hood on them so they can collect the air that they're exhaling, as well as monitoring how much oxygen they're breathing in. There can't be any leaks in that. Or if it's a ventilator circuit, there can't be any leaks. That's going to mess up the accuracy of the test. You would do this at rest and during steady state. You want to avoid anaerobic metabolism. You don't want to be weaning the patient. You don't want to suction them while this is going on. So just steady state, resting is when you do the test. So the patient's nutrition status is determined because once they calculate the energy expenditure, they can determine if the patient is being adequately nourished, whether they're being overfed or underfed or fed just right. All right, so calculating the patient's resting energy expenditure. First, they look at the respiratory quotient. If it's greater than 1, it tells them that they're giving too many carbohydrates to the patient. So a breakdown of carbohydrates produces carbon dioxide. I don't know if you ever noticed the cans of food. I don't know if we want to call it food. How about nutritional supplements that they give the COPD patients at the hospital? There's special types of, they're like not Ensure, but they're like high in fats, high in protein, and low in carbohydrates. Because COPDers have such a hard time getting rid of CO2, they don't want to give them carbohydrates. So again, that's being applied here where overfeeding, you produce too many carbohydrates. You don't produce carbohydrates. You're given too much carbohydrates and you produce too much CO2. Put that in the chat. Sentence isn't sounding good. Too much carbohydrates equals too much CO2 production. So I just wrote too much carbohydrates equals too much CO2 production. So when we have normal lungs, all we do is breathe a few extra breaths. We get rid of the CO2, but somebody's got obstructed airways, their CO2s in their blood go up after eating too many carbs. And then also the respiratory exchange ratio becomes higher than 1 if lactic acid is being formed in the cells. So that's what they're looking for. They're looking at the respiratory quotient or the respiratory exchange ratio. It's greater than 1, too many carbs, or there's lactic acid being formed in the cells. This Weir equation, I don't have you guys learn the equation, so why is it here? Oh, I don't even have any notes on it. This is what the computer does. It uses .94. I don't know where 3.94 comes from, multiplied by the amount of oxygen being consumed, plus 1.1, don't know where that comes from, times the amount of CO2 being produced. And from that, you get the amount of calories. Do we have to plug into the Weir equation? No. Just be familiar with the name of how they come up with the number of calories. So they use the Weir equation to come up with the number of calories to sustain basal metabolism. I think that's just fancy for saying the minimum calorie needs of a person. Normal should be somewhere between 1,200 to 1,800 calories in 24 hours. And then one thing here, it says KCAL, kilocalories. When we talk about calories, when we look on the the nutrition facts on the label of a box or something. And we see that there's 100 calories in a serving. It's actually kilocalories, but usually the K doesn't get printed. It'll just say calories. So here, seeing the K, just imagine it means the same thing as what we're used to seeing when we look at food labels. And that's it. Is there anything I need to clarify? I guess it's just a matter of going through it a couple times, getting familiar with the terms. So you have this lecture today. Next week, you have a blood gas testing lecture. So not necessarily interpreting ABGs, but when you run a blood gas in a blood gas machine, what do you have to know? And that's it. We review for the final exam. So 2 weeks from today is your final exam, and then this course is over. So much more doable compared to your spring semester last year. Did you guys notice I forwarded an email to you from Paul Chatromo at Memorial Regional. He's inviting you guys to a picnic. You got that?
Yes, I got that.
So he wants a head count as far as how many people are attending. So if you guys can email me and let me know so I can give him a head count.
Okay.
I hope that all of you can go because I want to make sure I have a good time and I need you guys there so I can have a good time.
I have to work that day.
What was the date again?
Oh my God.
It's on a Sunday, which is not the best choice. I think October 23rd, it's like the kickoff for Respiratory Care Week.
I'll be here.
It's
I'll
the
be in Philadelphia.
22nd.
We have a test that Monday. All right, we can work around it if that helps you.
Yeah, I'll figure out if I can go or not.
I love that positive energy. And what else did I have for announcements? I think that's it. Then I will sign off if nothing else needs to be said.
Thank you, Professor.
Thanks,
My
Professor.
pleasure.
Thank
You're
you.
welcome.
Thank you.
Bye.
Bye.
That's the due date for the